So friends, welcoming you to this wonderful CME. We start with Dr. Saptarshi Bhattacharya, who will open the innings for us on glycemic efficacy and the hepatic safety. Obviously, and we are talking of the combination. And what combination are we talking about? DPP4 inhibitors and SGLT2 inhibitors. Okay? Dr. Saptarshi Bhattacharya is Senior Consultant Endocrine in the Basta Apollo Hospital. He is Director E-Health Diabetes and Endocrinology Center at Noida. He is in the Executive Committee member of Endocrine Society of India, Founder Secretary of Delhi Endocrine Society, President's Award of Appreciation in 2021, Endocrine Society of India, Ex-President Society for Promotion of Education in Endocrine and Diabetes, SPEED, and he holds such wonderful conferences in SPEEDCon. Scientific Secretary Endocrine Week 2020 organized by ESI, more than 60 publications in national and international journals. You can go on and on. I invite Dr. Saptarshi Bhattacharya for his presentation. He will be speaking on this combination. He will also be speaking on hepatic safety of SGLT2 inhibitors and the combination. So over to Dr. Saptarshi Bhattacharya.
Sir, for the very kind introduction and the invitation to be a part of this August gathering. So it feels great to connect with all of you physically. So we have been doing webinars, but obviously physical meetings do have their own charm. You will miss a glass. they were that good to have it alone at your home while you were watching a webinar. And other than that, obviously, medicine and academics will connect all of us, but friendship is something which is also something to be cherished about. And when we talk about diabetes, I think one of the problems which has emerged recently and often gets ignored is diabetes and chronic liver disease. So diabetes and chronic liver disease is a problem, and we often have those doubts that which is the safest medication in the setting of diabetes and chronic liver disease. So if we go to a particular case, I'm sorry, it doesn't look like Mahesh, but it's a 52-year-old male, works as a cooperative executive, diabetic for 10 years, child ACLE, is apprehensive of injection, has hypertension also, already on metformin 1000 mg twice daily, atorvastatin 20 mg once daily, ramipril and amlodipine. So his fasting blood glucose is 120, postprandial is slightly high, A1C 7.4, EGFR slightly on the lower side, 51, and having bilirubin of 1.8, no ascites or encephalopathy. So this is something which actually we very often face. So most of our diabetic patients who undergo an ultrasound, we get a slightly coarser nicotexture, the SGOT, SGPT is slightly elevated, and we have our apprehensions over giving what should be the right medication in this particular situation. So this is all how we classify hepatic disease or chronic liver disease, and this person is fitting into child group A, having a score of 5 to 6. So what is important for this person is need for HbA1c reduction, need to improve his glycemic status, and the medication should be safe from hepatic point of view, and whether we need to modify the dose in the setting of chronic liver disease. So there are different parameters which guide our choice of medication. So as the disease progresses, we maybe the standard guidelines remains you start with metformin, but they have kept on changing, so we can even consider other medications like SGLT2 inhibitors or GLP-1 analogs at the beginning. Then of life is also important, and it's always, we know from studies like CACOT that for an elderly person, if you are going for very tight glycemic control, it might actually cause more harm than benefit, and so it has the glycemic control has to be balanced with the safety and the risk of hypoglycemia. So NAFLD and diabetes, we all know they are very intricately related. They have multiple mechanisms, and liver disorders. So most of the diabetes is going to overtake alcoholic liver disease or hepatitis B or hepatitis C liver disease as a cause of chronic liver disease in the next 10 years or so. So this is something which is really cause for concern. So we keep on talking about macrovascular complications of diabetes, microvascular complications of diabetes. And another thing which is very important is that if somebody is having liver disease, that itself also increases insulin resistance. So liver disease, it will increase the glycogen reserve, it increases the chance for hypoglycemia, but on the other hand, it also increases insulin resistance. So we need to strike a fine balance of avoiding hypoglycemia in the setting of liver disease and also to achieve the right glycemic control. And this was a study from India, which was, this is not a sprint which was done in US, but this is a study from India, and it re-established the clinical association of NAFLD with elements of metabolic syndrome. And we know that there are multiple studies which do suggest that what should be the ideal, that this is a major problem which is under-recognized. And to come to the more important part is that how we should manage patients with chronic liver disease and diabetes. So what should be the choice of medication? So initially patients can, in a compensated liver disease, there is mild to moderate hypoglycemia, maybe lifestyle change, but most probably there will be some need for medication, and these are the medications which are actually considered in many of the cases. So metformin remains one of the important medications. Then we have sulfur. The risk of fluid overload should be avoided. So the incretin-based therapies have been studied quite a lot. So vildagliptin has an issue with liver dysfunction. So if the SGOT and SGPT is more than 2 or 3 times, actually this is something which we often miss. We see a SGOT, SGPT of say 110 and 90, and we often tend to, if somebody is on a vildagliptin metformin combination, we often tend to ignore that, but this is something which we actually need to look into. So there are actually studies which suggest that vildagliptin should be avoided in the setting of chronic liver disease. Now if we look into linagliptin, so it has primarily biliary excretion, so it does not get metabolized in the kidney. The other medications like vildagliptin, it's primarily metabolized in the liver. Sitagliptin primarily excreted unchanged in the urine. Saptarshi again has active metabolites. So linagliptin is a molecule which is quite safe for chronic liver disease as well as chronic kidney disease, and there are not many studies of the gliptins in the setting of child cook C. So most of the gliptins, other molecules have been studied in child cook A and B, but very few studies with child cook C. So there are, in fact, linagliptin in their approval phase 3 studies, they did have some studies and it did not have a negative impact on the liver related outcome. Even there are studies with empagliflozin which suggest that they are actually safe in the setting of chronic liver disease. So linagliptin, hepatic impairment, there is a meta-analysis of efficacy and safety. So 60% had hepatic steatosis, and the exclusion baseline was more than AST, ALT, or 3 times upper limit of normal. So there was a consistent HbA1c reduction with linagliptin. Again, the linagliptin pharmacokinetics was not impaired by hepatic impairment, and it was quite safe. There were no adverse effects related to linagliptin, and even there are Indian studies and consensus statement where linagliptin has been proposed as a molecule which can be safely given in most of the chronic liver disease. So you can actually, so sometimes the patient is having child cook B and even a child cook C in some cases. We not very robust evidence for child cook C, but for child cook A and B, you have adequate evidence where it can be safely given. Though most conventional studies will suggest insulin. Even there are studies with metformin. Metformin had been So there was a lot of myth around metformin that it causes kidney damage, it causes liver damage. So thankfully things have changed, so it's quite clear metformin is safe. If the GFR is more than 30, you can safely give metformin. If even for the main risk related to liver disease and metformin is again lactic acidosis. It does not damage the liver, it does not have any negative impact on the liver. It's only if somebody is having some risk of increased lactic acidosis, if the patient is actually having decompensated liver disease, maybe hepatic encephalopathy, fluid overload, ascites. So this is a situation where metformin needs to be avoided. Otherwise, linagliptin and metformin combination can be safely given to most of the patients. Limipedide will cause a chance of hypoglycemia, so it should be given carefully. It has hepatic excretion, so you should be careful. Again, linagliptin has been studied at different duration of diabetes, at all ages of diabetes, and different background therapies. In most cases, it's quite safe. So to summarize, linagliptin is quite safe. Maybe you do not, for if somebody is having childhood A and B, you most probably need to avoid vildagliptin. Other medications do not, most probably are safe, but like other gliptins, most probably are safe, but they do not have that much of safety data to back their usage. Atorvastatin, there is again some confusion about atorvastatin, that whether you can give atorvastatin to patients with normally, say NFLD or childhood A and B. Again, it's actually, if the cause is metabolic disorder, you need to give atorvastatin. Atorvastatin will cause liver dysfunction very, very rarely. It's a safe molecule. So just because the SGLT or SGPT is slightly high, or you have a increased fibroscan score, so that does not mean you need to stop atorvastatin. And what we need to understand is that insulin still remains the gold standard. Metformin is safe up to childhood B, childhood C. You really need to be careful. Most of the gliptins are safe apart from vildagliptin. Linagliptin has the maximum data to back its usage. Sulfonylureas, you need to be really careful. Pioglitazone has been studied as a drug which actually might be beneficial for NAFLD, but if somebody is having decompensated liver disease, there is an increased chance of say osteoporosis with pioglitazone. Even there is an increased chance of fluid retention. So, and there are other factors also which there are negative effects of pioglitazone which are there. So you really need to be careful with its usage. So the other medications like maybe acarbose and goclibose, if you have a situation where the postprandial blood sugar is high, you can consider. But even if you are really having a decompensated liver disease, still insulin remains the optimal and safest therapy. But again, the risk of hypoglycemia remains a real concern. But if we compare to linagliptin, it's a reasonably safe molecule with reasonable data to back its usage in the setting of chronic liver disease. Thank you. I now
thank you, Dr. Saptarshi Bhattacharya. Wonderful deliberation. And my apologies, since I have always been speaking on the combination and hepatic safety, I thought it was another talk and I never saw the topic which was the uppermost. So I have requested Dr. Sanjiv Gulati sir to speak on the combination also, his views on apart from linagliptin also on SGLT2 inhibitors, because we know there is a great emerging role of SGLT2 inhibitors in liver safety. Now it's my duty to introduce Dr. Sanjiv Gulati. Although he does not need any introduction, at least to the forum. If you would remember from 2011, the first CME we had on presenter for linagliptin, it was in a place called Parkland. You remember? Yes. Okay. It is when Dr. Sanjiv Gulati was the first to partner me in the presentation on linagliptin, and we became a fan of each other. He never knew that I could be a speaker, and I never knew that he had such vast depth of knowledge. Since 2011, although we are both Moranians, I happen to be 1 year senior to him, and he has been a very, very worthy junior. Traveled a very, very long distance from Maulana Azad to become the Director of Nephrology in Fortis Escorts Group, and is one of the best nephrologists in North India. Congratulations, sir, for being selected the President of Indian Society of Nephrology. Dr. Sanjiv Gulati is at present the Chairman of Nephrology at Fortis Institute of Renal Sciences and Transplant. His present affiliations are Fortis Institute of Renal Sciences and Transplant and the Vasant Kunj and Fortis Escorts Art Institute, Okhla, New Delhi. His major achievements include ex-additional professor nephrology, DPP4i, Lucknow, ex-associate professor, McMaster University, Canada, secretary, North Zone chapter of ISN, co-organizing secretary of ISKCON 2017, Delhi. He is a fellow of the Royal College of Physicians, Canada, and he has multiple other international fellowships. His awards include the Bansal Oration of ISN, Khular Oration ISN, Arogya Kalyan Niyaz Oration of PDSI, J.M. Patel Oration ISOT, ISM Award for Research. Ladies and gentlemen, let us welcome our own, one of the best friends of Physicians Forum of India, a nephrologist par excellence, above all, a human par excellence, Dr. Sanjiv Gulati. He will be speaking on the glycemic efficacy and the renal safety of linagliptin. Just one word, when linagliptin was launched in 2011, Yamin came to me. We were all writing sitagliptin at that time, and he asked me, "Sir, how to place this molecule?" I said, "What is your molecule?" And he said, "It is a DPP4 inhibitor." And I asked him how good it is. He said, "Sir, it is very good for kidney." I said, "Great." But I asked him, "Is it good for diabetes?" He said, "Yes, of course, it is good for diabetes." I then asked him, "You are onto a self-destructing and self-defeating path. You have such a wonderful DPP4, but you tell all the physicians that you use this molecule only once your patient gets CKD. Don't use it before that." And I think they realized their mistake, and then I gave them a slogan called Lina Hi Lena, which they have followed it today, Lina Hi Lena. Over to Dr. Sanjiv Gulati. I have requested him to say a few words on SGLT2 inhibitors. There is a combination of linagliptin and SGLT2 inhibitors. SGLT2 inhibitors not only have a role in hepatic protection, not only on gross basis but also on histological basis. You remember the E-lift study, but also as far as kidney is concerned, they are the best molecules. And linagliptin, you fill it, forget it, and you fill it, shut it and forget it kind of a molecule. Over to Dr. Sanjiv Gulati for more. Thank you, Sushil, and good evening, friends. It's a privilege to be in my 12th year of association with Physician Forum. I think it's been a wonderful journey. I've always relished both the academics as well as the fun that we have in these meetings. So I'll be taking you through over the next few minutes about a nephrologist's perspective about linagliptin. So we'll look at a case, and the challenge is achieving optimal management of glycemic control in a patient with chronic kidney disease. So this is a 55-year-old lady who's working as a school teacher who complains of heavy tingling of toes and fingers, sleep problems, recurrent history of urogenital infection, who's been diabetic for 7 years, family history of cardiovascular disease is not known, and in addition, non-standard terbisart, which most of us would be using. So it's a common garden case that you see, but now let's take a look at her investigations. So HbA1c is 7.8,
fasting sugars 135 and 210. ECG is normal, blood pressure 106/70. When you look into, as we have always talked, we don't talk about creatinine, and EGFR is just 30, and she's got a urine arbitration ratio of 130, and LDL cholesterol of 110 despite being on a atorvastatin. So if we stage her, this is how we talk about kidney disease now, G1 to G5 and A1 to A3 depending on the proteinuria. So she has got stage 3B8. So she's got moderately severe chronic kidney disease. So what is the main concern when you look at the next steps? Certainly we need to look for HbA1c reduction. The kidney function is declining. We need to put into place measures to slow down the decline. No modification of the medication is a concern. And in addition, she's had recurrent UTI. So what treatment goals would be recommended for this lady? Well, obviously HbA1c less than 7, and at the same time, we'll be looking for a renal safe molecule. So this is the global prevalence of diabetic kidney disease. In our studies from SCBJ in Lucknow, we were among the first to point out that diabetes had rapidly emerged as the commonest cause of chronic kidney disease as far back in our publication in 1999. Subsequently, our studies were validated by data from PJ Chandigarh as well as All India Institute of Medical Sciences. Now, what are the challenges in optimizing glycemic control in CKD? The dose adjustment of cessation may be required for oral anti-diabetic drugs excreted by the kidney. I think the commonest, the one thing that whenever a patient walks into my clinic and has dry cough is obviously glimepiride because of the risk of hypoglycemia. With declining renal function, there is a decreased clearance of insulin, so you relook at the insulin dosage. There is need to avoid hypoglycemia, there is reduced renal gluconeogenesis, and there is declining renal mass. So the management of glucose levels is particularly challenging in these patients with the concomitant need to avoid hypoglycemic events which we all read, while managing the renal comorbidities which is often associated by cardiovascular disease and other significant comorbidities. And mind you, the EGFR is not fixed, it's a moving target, so every time you need to relook at the dose, what dose are you using, what drug are you using. So, we all have known that the risk of hypoglycemia is increased several-fold in chronic kidney disease. These are patients, this is the risk of severe hypoglycemia. So we start off here at no CKD, no diabetes. The moment you have chronic kidney disease with diabetes, 1.6, it goes up to 4.1. If there is just diabetes, and if you have both diabetes and chronic kidney disease, it's 8.4. So we decline, and the reason is that with declining renal function, there is decreased clearance of insulin. I'm sure you would have all seen patients in your clinic who come to you saying that my diabetes is getting better because the requirement of insulin is getting lower, and the reverse is true. You get a kidney function done, the root dictum is make sure that you do an EGFR, and I'm sure this patient will have kidney disease. Now this is the plethora of agents we currently have in our therapeutic armamentarium. So these are good old sulfonylureas, very good in naive patients, there's no doubt about it. But the moment you have kidney disease, there is increased risk of hypoglycemia because of the renal clearance. Same is the story with insulin. Then we have type 2 thiazide, we have edema, heart failure, so certainly we stay away from this. Metformin can be used safely right up to stage 3, but beyond stage 3, there is risk of lactic acidosis. And then we have GLP-1 analogs, DPP4 inhibitors, SGLT2 inhibitors, and these are great drugs until advanced chronic kidney disease, where DPP4 inhibitors still retain their therapeutic efficacy as well as safety, but the efficacy of SGLT2 inhibitors does decrease in advanced chronic kidney disease. The other issues are with GLP-1 is the cost injectable therapy, but we now have an oral analog on the horizon. So therefore, it's not difficult to understand why DPP4 inhibitors have emerged over the last few years as the favorite drugs as far as the chronic kidney disease patients are concerned. The other reason is, which is not class specific but drug specific, and that is linagliptin. It has got proven efficacy and safety across the entire spectrum of chronic kidney disease, from mild renal insufficiency, moderate, severe renal insufficiency, and severe disease and dialysis. And not only that, new onset diabetes after transplant, and it shows preserved EGFR over 1 year, and as you can see, robust HbA1c reductions. So you don't need to bother about you certainly should be calculating EGFRs for a host of other reasons, but you don't need to constantly look and relook at your doses. And this has also been more important in the pandemic, where we have had quite a difficulty in having face-to-face communication, and investigations have been very difficult to do. So this drug, I think, has proven its value in the last couple of years. Now, the efficacy and safety of linagliptin remain constant across all stages: stage 1, 2, stage 3, stage 3B, stage 4, stage 5. So uniform HbA1c reductions. Not only that, talking about new onset diabetes after transplant, which is a problem that we see in about 15 to 30% of our patients, it has adverse outcomes in terms of increased rate of hospitalization, reduced rates of allograft survival, and patient survival. And the mean HbA1c reduction of 0.8 at the end of 1 year with no hypoglycemic event in patients with linagliptin is very, very reassuring. And this drug, especially in the post-transplant setting, stands apart because of its placebo-like side effects. There is no interaction with any of our other immunosuppressive agents. Now, we all know this, but just to quickly recapitulate, the cardiovascular safety of DPP4 inhibitors in patient with kidney disease has appropriately studied only in the Carmelina trial. So the safety of linagliptin in patients with kidney disease was appropriately studied because nearly 3/4 of the patients here, as you can see, with linagliptin either had reduced EGFR less than 60, less than 30, or macroalbuminuria. None of the other gliptins comes even anywhere close to this, and that gives you confidence in using this molecule at least in the renal subset of patients. So Carmelina demonstrated long-term kidney safety with linagliptin. There was a 14% lower risk of progression of albuminuria over the 2.5 years it was looked at, and 15% greater likelihood of significant regression in urine albumin creatinine ratio. It caused increased natriuresis, diuresis, reduced glomerular hyperfiltration, protein filtration, tubular interstitial fibrosis, and podocyte loss. And these were the potential kidney-related beneficial effects that we all look for in our patients. So the learnings from the Carmelina trial: risk of reduction, 14% lower risk of progression of my albuminuria, 15% greater likelihood of regression of microalbuminuria. And both of these are surrogate markers for progression of kidney disease. Now, linagliptin improves urine albumin creatinine ratio of nearly about 20% reduction in urine albumin creatinine ratio in patients with type 2 diabetes who had early signs of kidney disease, as shown in the Marlina type 2 diabetes trial. And so this is in the responders, these are the non-responders, and so it showed its metal here also. And this is the Carmelina randomized control trial. The summary of it: nearly 7,000 patients studied. Out of this, 646 were younger and lower EGFR. Mean urine albumin creatinine ratio was nearly 3,500 milligrams per gram. And this is 3-point based. It was neutral as far as heart failure, cardiovascular death, all-cause hospitalization, or renal death and end-stage kidney disease is concerned. But at the same time, it showed improvement in albuminuria and glycemic control. Now, how does it work at the renal cellular level? Linagliptin, actually, as I mentioned earlier, it's a drug effect and not a class effect. When it was compared to sitagliptin, linagliptin inhibited the transforming growth factor beta and endothelial DPP4 activity in the endothelial mesenchymal transition. Now, these are mediators of fibrosis, and fibrosis means irreversible kidney damage. So linagliptin can inhibit the endothelial to mesenchymal transition and thus ameliorates diabetic kidney fibrosis and progressive kidney disease. As I said, this was drug specific. In addition, it inhibits the podocyte injury and the part of the glomerular filtration barrier. There is inhibition of myofibroblast transformation. There is also increased GLP1 receptor expression. So there is a theoretical basis also at the cellular level of the renoprotective effects. And these are the different pharmacokinetics of all the gliptins. But as you can see, linagliptin has got a predominantly hepatic excretion, and it's a highly selective molecule which allows you to use it in advanced kidney disease and also in a very, very small dose of just 5 milligrams in compared to, because of its high selectivity of this DPP4 enzyme. As I mentioned, just 5% is renal excretion, so no dose modification. Now, these are studies which show that a significant proportion of our patients who have got chronic kidney disease receive an unlicensed or an inappropriate dose in real world. Obviously, linagliptin doesn't require any dose modification, so there was in this study there was no inappropriate dose, but as you can see, anywhere between 27 to 48% with different gliptins were being used inappropriately in patients with chronic kidney disease. And this has its own issues. This is from the Korean National Database, looking at nearly 82,000 patients, and 1 out of every 3 patients on DPP4 at inappropriate dosing. 2 out of 5 is CETA, 1 out of 4 is linagliptin, but no patient is benefited. Now this is again from the same database showing that this does have its effect, and this is the all-cause mortality in these patients with the hazard ratio of 1.12 adjusted, and this is the severe hypoglycemia with 1.19. So linagliptin has proven cardiovascular and renal safety across the spectrum of chronic kidney disease. It has been shown it's not harmful to the heart or to the kidneys. So the new treatment regimen in this lady could be a reduction of the dose to 500 twice daily along with linagliptin, telmisartan, and an increase in the dose of atorvastatin. So the key learnings are proven efficacy and safety across the spectrum of chronic kidney disease, no dose adjustment, and a very long half-life ensuring effective 24-hour glycemic control. So this is the PFI slogan: buy it, take it, and forget it. You forget it, don't forget to take a dose, but you can forget to monitor the dose. As Sushil rightly said, any questions, so we can take them at the end.
Thank you, Dr. Sanjiv. We would love you to wait till we have the question and answer session and some socializing. And people are asking for a party for you becoming the president of the ISL. Friends, on to the last talk. We have Dr. Viveka Kumar. Dr. Viveka Kumar is at present working as senior cardiologist and director of Cath Lab PanMax at Max Hospital. He doesn't need an introduction to the forum, does he? No. He doesn't need an introduction to the forum. Sir will be speaking on achieving optimum management in elderly patients with high severe risk with hypoglycemic episodes. Let's first congratulate Sir for becoming the president of the New Delhi branch of IMA.
Being the last speaker, it's always my duty to finish things in time so that I don't stand between you and the dinner. But first of all, thank you all for being here, and I wish all of you a very happy Holi, which is not too far. It's a couple of days from now. For that, I must thank again Dr. Chauhan and all of you for being a big support. So I think there's a lot of things that have been told about linagliptin, and I'll just briefly give you the cardiac perspective. And we know that we need, as a cardiologist, a molecule which does not cause huge swing in blood sugar level does not cause hypoglycemia, because each episode of hypoglycemia is something which is really, not good, can precipitate. So that is why if you look at the ACCORD trial, there was, despite using insulin, the incidence of strict glycemic control, incidence of cardiovascular event rate and mortality was significantly higher. So we were always looking for a molecule which does not cause significant hypoglycemia and does not increase the event rates. So there is a common garden variety case where 67-year-old person who was retired a couple of years back had diabetes for 10 years, which I think Dr. Saptarshi, Bhattacharya and all would be eating day in and day out. But initially, these were the people who have had on a conventional therapy. If you see here on metformin, and simvastatin, Dr. Gulati has said in his talk that once the stage 3 CKD comes, then we should try and avoid metformin. Then very few people did know that you can give molecules with up to end stage disease which is safe in this situation, and that is this molecule of linagliptin. So if you look at the physical examination and all, this patient was unremarkable, but on this the patient had frequent hypoglycemic episodes, and based on that because of that he had palpitation, sweating. So in cardiac patient we don't really want this. So what is your main concern considering your next step? So basically we need that need for HbA1c reduction, because we now know that even if you don't control the HbA1c, so how do you control your blood sugar level is with what molecule is more important in cardiovascular safety than the strict blood sugar control alone. So we need to have HbA1c reduction for sure, but we don't really want the hypoglycemic episodes to happen, and we know the cardiorenal continuum, and we don't really want the kidney function to deteriorate fast. So this is the important predictor, because we know as a cardiologist that if the renal function deteriorates further, the cardiovascular mortality is significantly higher, the event rates are higher, so we want to preserve the kidney also. So like a nephrologist, now, so there is a coordinated care. So endocrinologists, nephrologists and cardiologists have become good friends. At one point, they were competitors, but now we are very good friends, because the molecules are so that they have bound us together, the event rates. So now we know cardiorenal continuum, we know that diabetes, almost 63% of diabetic patients they die because of the cardiovascular diseases. So we need to really control the HbA1c, and we know that it should be less than 7% and reduce the risk of hypoglycemic episodes. So the reason why we like so much of SGLT2 inhibitor and the DPP4 inhibitor, especially linagliptin, is that they prevent hypoglycemic episodes. They are easy to use, once a day you can use, and then as Dr. Chauhan said that you can feel it, shut it and forget it. So you don't have to really worry much about the whole thing. So diabetes is associated with significant loss of life. I have already said that. If you see that on average 50-year-old with diabetes is approximately 6 years younger at time of death than counterpart without diabetes. It means that they would die younger, and we call it vascular age. So vascular age is significantly higher if you have a diabetes compared to. So a lot of patients come to me and say that, doctor, can I stop these medicines? I say only one way, and that is if you become younger. So they say, what are you joking, sir? How can I become younger? So I said, no, you can become younger. You can become, your vascular age can become younger. So when we say you become younger, it means that, in local lingo, people say you detoxify yourself. So similarly, you have to have, so I tell you, if you are smoking, stop smoking. If you are not exercising, start exercising. So basically, power of lifestyle modification is very, very important. On top of that, the anti-diabetic medication, and which anti-diabetic medication you take is also very important. So it is like a ticking clock hypothesis. The clock of coronary heart disease starts ticking before the onset of clinical diabetes. And there are a lot of data that the person who has diabetes has got worse outcomes and more cardiovascular event than those who do not have diabetes. But not only that, also the patients who are pre-diabetic, means that the diabetes has not set in yet, still the cardiovascular event rates are significantly higher. So we need to have a, how to modify the cardiovascular risk in diabetes is that we need to have a multifactorial approach. We need to have lifestyle modification. We need to have glycemic control. We need to have, management of dyslipidemia. So, cholesterol has to be well controlled. Also, we need to control the platelet aggregation to fight anti-platelet activity. Again, in the COVID era, we have seen that COVID was the most inflammatory disease we have ever seen, causing in situ thrombosis. We have been done primary angioplasty of as young as 23 years old females and all, where we never suspected that they would have any problem. And we saw that, biomarkers like CRP, interleukin, D-dimers, they were so high, and those patients with coronary artery disease was high. And now, there is a editorial just published yesterday in Lancet that are cardiologists ready for the pandemic of cardiovascular disease post-COVID, because the amount of multiplication of cardiovascular disease has gone really high. So we need to keep the inflammation down, and these diseases, especially diabetes also, these associated risk factors for heart disease are one of the, they provoke a lot of inflammatory response is important. Hypoglycemic episodes and cardiovascular risk is very important. So we need to decrease the episodes of hypoglycemia. So as I was saying that hypoglycemia is associated with MACE and all-cause mortality across the diabetic landmark trials. So whichever trial is it, so what we call glycemic variability. So if your sugar is waxing and waning, once it goes into hypoglycemia, then hypoglycemia, so that is not good. And we have got data right from the ACCORD, ADVANCE, EXAMINE, ORIGIN and LEADER and the DPP4i trial. All of them have really shown that if you induce hypoglycemic episodes, the cardiovascular disease would be precipitated. So why would linagliptin be a good option for our index patients? If you see the long-term glucose lowering efficacy of linagliptin is comparable with the clinical trial. So we always say that sulfonylureas are much more stronger molecules as far as the sugar control is concerned, but when you compare it to the linagliptin, it's not inferior. And at the same time, if you see the episodes of hypoglycemia and weight gain, that is significantly lesser with linagliptin compared to the sulfonylureas. So with linagliptin, more patients achieve target HbA1c levels without hypoglycemic events or weight gain compared to the clinical trial. So it means that two things which we don't really want is hypoglycemia and weight gain. These things do not happen in our patients. So with linagliptin, more patients achieve the target HbA1c level without hypoglycemic event or weight gain compared to the sulfonylureas. Similarly, if you see patients with kidney disease, we need to have more research. So we have seen that Dr. Gulati has already touched upon this, that data from DECOS, Carmelina, we have seen that in DECOS the cardiovascular risk increased in with the other DPP4 inhibitor, but when you look at the linagliptin, that was not. So that is why the patients who have got renal risk, the Carmelina and Carolina did show linagliptin has been studied in patients across the cardiorenal risk continuum, and here it is something which has shown to improve the outcome. So if you look at the hospitalization due to the heart failure, cardiovascular death, DPP and renal outcome, all these would be significantly lesser with linagliptin compared to the other gliptins. So that's the reason why this is so important. So if you see the compare with other gliptins, linagliptin has got much better safety profile, and it is good that it is just once a day molecule, so you can give it once a day any part of time. So there is no increase in hospitalization due to heart failure. So one of the DPP4 inhibitors which were having a problem was that the increased hospitalization due to heart failure was there. But with the linagliptin, it is not there. So that's again a plus point in our case. If you look at the subgroup analysis, whether Asian group, whether patients who are North American group, and also patients not on insulin at baseline, the subgroup analysis was not statistically designed to evaluate the outcomes independently. So much such evidence must be viewed as hypothesis, generating only not a confirmatory evidence, but definitely, linagliptin showed no increased risk of hospitalization due to heart failure in subgroups. And when you combine it with the SGLT2 inhibitors, the hospitalization due to the heart failure has almost 42% reduction is there. So when you give a combination of linagliptin and SGLT2 inhibitors, you are winning the war against the cardiovascular disease. So if you see the guidelines, EASP guidelines 2019, that also shows that DPP4 inhibitor in patients with diabetes and heart failure, linagliptin would be the drug of choice. Now it has not, as bad an outcome as it was initially thought of with other DPP4 inhibitor, but definitely linagliptin would be something which is really superior. And Carmelina showed that linagliptin did not increase the hospitalization due to heart failure as compared to the baseline. And whatever the patient history be, renal impairment, atherosclerotic cardiovascular disease, patient with insulin use, anywhere, and even elderly patient, it was pretty safe. So, if we go, the conclusion of this study that showed that, that this is linagliptin is something which is really, very safe in this, and so if we come back to our patient who was on metformin, based on these studies, we need to put him on linagliptin also, and ramipril he was there, amlodipine to control the blood pressure, and simvastatin to control the status. So we need to control all the risk factors of diabetes without provoking the hypoglycemia. Blood pressure has to be well controlled so that we reach the target, and then the lipid profile should also be well. So these are the deadly triads for the cardiovascular diseases: high blood pressure, high sugar, or sugar control with hypoglycemic episodes, and high cholesterol. So these things has to be controlled. So what are the key learnings from this patient? It is that the linagliptin can help simplify patient management due to its proven efficacy similar to glimepiride. Linagliptin has proven cardiovascular and heart failure safety, and it reduces the risk of hypoglycemia and is great neutral. So that is very important as far as the diabetic management is concerned, hence beneficial in elderly type 2 diabetic patients. And linagliptin has proven cardiovascular safety, renal safety across the spectrum of CKD and diabetes. So as you remember that the diabetes and renal continuum, the patient after 6 months or 1 year they would have the degradation of renal function. Also, you don't have to really say the number of patients visit to their doctor would also be decreased, because you are not worried that even if the renal function deteriorates, you need to change the drug and all if the patient is on linagliptin. So I think I would conclude on that note, and thank you very much for your kind attention. And if there is any question, you can ask other two speakers, not me, because